Hi everyone. Today I will be presenting my analysis of HIV/AIDS epidemiology and control in New York City. We'll explore how New York City transformed from being the epicenter of America's HIV epidemic to becoming a national model for epidemic control, while examining the persistent challenges that remain. To over the next 15 minutes, we'll walk through New York City HIV journey. We'll see how the city went from having 14,000 new cases annually to fewer than 2,000. Examine who's still been affected and discuss both the innovations that work and the challenges that persist. To understand where we are today, we need to look back in the 1980s and 90s. New York City was ground zero for America's HIV epidemic. At its peak in the early 1990s, the city was seeing more than 14,000 diagnoses every year. Fast forward to 2019, and we see only 1,772 new diagnoses, a 70% reduction since tracking began in 2001. This transformation didn't happen by accident. Understanding your unique challenges. New York City demographic create unique challenges for HIV control. With over 8 million people packed into 300 square miles, making it to one of the world's densest urban population. But there is the kid inside. While the median income may look decent at about $80,000, there are extreme variations. This most telling statistic is that 83 of new HIV cases occur in areas with moderate to high poverty levels. Looking at 2019 data, we see the epidemic is highly concentrated. Nearly 80% of new cases are among cisgender men, men who have sex with men, representing 54% of all new diagnoses. The racial disparities are stark. Black and Hispanic Latino individuals make up 73 of percent of new cases. Perhaps most concerning is that 40% of new infections are occurring in young people aged 13 to 29. The challenge and disparities that persist. Despite our progress, disparities remain troubling. Black New Yorkers are being diagnosed with HIV at a rate 7.1 times higher than white residents. Geographic disparities are equally stark, with the Bronx and Brooklyn bearing the heaviest burden, even in virus suppression, where New York City excelled over at 87%. We see gaps among the most affected community. New York City surveillance innovation in action. New York City surveillance system is a model for other cities. The Care Continuum dashboard, launched in 2012, gives healthcare providers real-time data on their performance. This comprehensive registry contains over 10 million lab results for more than 240,000 people. The system tracks two critical metrics: how quickly people get into care after diagnosis and how well they are suppressing the virus. Ending the Epidemic Initiative. The Ending the Epidemic Initiative, launched in 2014, focused on three core strategies, but what made it work were the policy innovation, removing barriers like writing consent for testing, expanding data sharing between providers, and recognizing that housing stability is healthcare. These weren't just medical intervention, they were structural change. New York City versus national performance leading the way. The results speak for themselves. New York City, 87% viral suppression rates among people in care, in um, 30% points higher than national average for all people with HIV. HIV related deaths have dropped by 81% since 2004. New York City became the first major US city to get new diagnosis below 2,000 annually. This isn't just good, it's exceptional by any global standard. Challenges that remain. Success hasn't eliminated challenges. Structural racism continues to drive in disparities. Housing instability make it nearly impossible to maintain consistent care. The rollout of molecular surveillance without adequate community engagement damage trust. COVID 19 showed how quickly progress can be disrupted, with services interrupted and disparity widening. Bridging the Gap Mobile Prevention Program. To address persistent disparities and proposing Bridging the Gap, a mobile prevention program targeting the hardest hit neighborhoods in the Bronx and Brooklyn. The key to innovation isn't just a mobile unit, it's the community driven design with peer navigators from the affected community themselves, plus transparent data practices that rebuild trust. Implementation framework. Implementation centers on meeting people where they are. Mobile vans will provide services into the community that need the most. Peer navigator will be helped with everything from insurance and enrollment to medication adherence. The community advisory board ensures this isn't another top-down program, but truly community-driven innovations. Putting New York City in global context, surrounding suburban countries haven't lowered diagnosis rate but haven't achieved New York City dramatic improvement. Internationally, New York City performs comparable to London and far better than resource constrained setting in sub-Saharan Africa. New York City advantages concentrated resource, political commitment, and population density create opportunity that other areas may need to approach uh, differently. Lesson for New York City HIV response. New York City experience offer clear lessons. Comprehensive surveillance, evidence-based policy, and sustained political commitment can dramatically reduce HIV transmission. But lasting equity requires addressing structural racism, maintaining community trust, and ensuring that innovation reach the community that need them most, not just those easier to serve. In conclusion, New York City HIV response demonstrate what's possible when public health systems work effectively. A 70% reduction in new diagnosis and viral suppression rates, 30 points above the national average, prove that epidemic can be controlled. But persistent disparities remind us that technical solutions alone aren't enough. Real epidemic control requires addressing structural inequities and building genuine partnership with affected community. Thank you for your attention and happy to take questions.